Welcome to the session called OpenSAFELY, a new paradigm in EHR analytics and research. My name is Ian Green. I'm the Customer Relations Lead for Europe and Clinical Engagement Manager for SNOMED International. And the presenter today is Dr. Chris Bates from TPP.
Excellent. Thank you very much, Ian. Hello everyone. So my name is Dr. Chris Bates, as Ian said, from TPP, of which a little more later. And I'm going to talk to you about OpenSAFELY, this new concept that we've designed for EHR analytics and research during the COVID pandemic, and as part of the research and analytics response to that, in collaboration with universities in the UK and with the UK NHS. And really, what I want to do is to tell you the story of what happened really in a very quick sprint, a 42-day sprint, from an initial phone call to the first published results we had for COVID-19. So what happened was there was a request that came down from NHS England, but working with academic partners at the University of Oxford and the London School of Hygiene and Tropical Medicine, to say on behalf of the NHS, can we stand up, a huge analytics research platform to try and help with the response here, and with support from NHSX, who are the digital arm of healthcare for the Department of Health in the UK. And really, we just want to talk you through how that happened, and with a group of people who most of whom haven't met in the real world so far. So just a combination of Slack channels and Zoom and GitHub, how we went from a standing start really to what we think is the largest global EHR research platform for COVID-19, and then to give you an indication of how important SNOMED CT has been for us as part of that journey in order to get powerful international scale results. So first of all, just a little bit of context. So like I said, I'm the research director at TPP, and we are a clinical systems and EHR provider based in the UK. So we've been doing integrated care and connected care from the very start. So we've been working with the NHS for about 21 years. And for those of you who are not familiar with UK healthcare, UK primary care research records are primary care health records are very comprehensive. That the general practitioner, the family doctor record, is a true cradle to grave record, and contains lots of powerful information around diagnoses and symptoms for patients and their medication, throughout a lifetime. So it really is a very, very powerful resource. In the UK, we host those records for more than 50 million patients, spanning lots of different care settings, including emergency department, acute hospital, and mental health trusts. But really, for this part of the story, most important there are those GP records, those comprehensive records, and we have our system in place for around 2,700 of those practices. The other sort of major collaborators here were the University of Oxford, specifically the evidence-based medicine team, data lab based in Oxford, led by Dr. Ben Goldacre, who I'm sure many of you are aware is giving the keynote for this SNOMED CT Expo. And of course, as always with Ben, I'm sure that'll be entertaining and well worth listening to. Ben has a team of epidemiologists and developers at EBM who are doing some really innovative things in terms of data science and health data science, with the express goal of improving medicine using that evidence, but importantly using that data. And then the final collaborator really was the London School of Hygiene and Tropical Medicine, who have a specific dedicated electronic health record research group, certainly one of the best research groups in this area in Europe, if not in the world. And that's, again, there's a broad range of expertise from epidemiologists, statisticians, and clinicians, and they have extensive experience of analysing and working with real-world data, including SNOMED CT recorded data in routinely collected care, as we'll see. So we really started to have a conversation based actually on some other research we were doing at the time, or wanted to do, but by the time we came to actually discuss this additional research, which was really around pop-ups and clinical decision support in digital systems, COVID had loomed large and was now, a real pressing threat, and the emerging challenge that we've all seen. So the question quickly became, in the context of a global emergency, can we create a new, very, very secure, safe, but massive research platform for EHR research for the pandemic, and can we do that very, very quickly? So what happened then was a kind of, as you would expect, lots of parallel streams of ethics and governance, but also technical streams, and then academic and research streams. So we started all these in parallel from that initial conversation, and then came to develop this platform. And I think just to start with some of those the technical aspect of this before we get onto the data is probably quite important. So at TPP, we have always been a cloud-based solution, which means that all the data we have for electronic health records lives in accredited data centers and is stored remotely off-site. And people access that data, you know, when you turn up to see your doctor, you turn up at hospital, then that's the record that's being used for your direct care, for prescribing medication, for example. And traditionally, I think it's fair to say lots of analytics and research have been done by taking data off-site away from the actual location, you know, the in-situ location where the EHR vendor may be storing that data for direct care. But we knew we didn't have the ability to do that if we wanted to do this quickly and at scale. We knew that for a start, we wouldn't be able to move that data around. We knew there'd be governance challenges around that. We knew that we'd then need, you know, infrastructure in different places to support that, and that really wasn't a possibility. So from the start, the idea was, let's build this analytics solution inside that data, inside that existing secure infrastructure with all the permissions that are there already. And we start with the level 1 data, which, as I say, is that data that is identifiable to you and to me. You know, from my record and your record, if you're seeking care and you're needing treatment from a doctor. So it includes your names and addresses and your extraordinarily detailed medical history in order for people to make better clinical decisions on the back of that. And of course, that's very, very confidential information, and that needs to be treated with, you know, the utmost concern and respect, and the security has to be at the forefront of everything we do there. But it's also very, very powerful data. And I think historically we've had a challenge between using that, well, you know, high dimensional, very powerful data, but maintaining patient confidentiality and maintaining the trust of being able to do this research, but actually get the powerful results out. So the approach we took here was kind of twofold, which is slightly different. We first built a second layer, a level 2 data, which is the way so this is de-identified data. So the sorts of things you'd expect. Of course, there's no national identifiers for people. There's no names, there's no addresses, there's no telephone numbers, email addresses, any biometric data, any narrative text or unstructured data. So it's coded data, mainly with SNOMED, as we'll come on to. And it has, you know, it has been de-identified. However, of course, that's still potentially very disclosive data. You know, it will say very specific facts about, you know, someone who was diagnosed with a certain condition on a certain day, or someone who, you know, Ben will often say in his examples, you know, had twins in one city and then a child in another city another time later, which can be used to, you know, that's a very small range of people, and you suddenly start to get disclosure where you didn't expect it. So actually minimizing access to even that de-identified data is very important. So we built another layer on top of that. This is what we call level 3 data, which has got it's anonymized data at this point. It's aggregated and it's far more low dimensional, but you can still do the epidemiological research and the analytics you want. So the research teams, say at London School of Hygiene and Tropical Medicine, can do the work they want to do, but they haven't lost the power of that data. So what does that mean sort of as a real example? Well, if we walk through an example here, at level 1 data, for my fictitious patient, Mrs. Jane Peters, we'd have her national identifier. We can see there that on the 7th of August 2015, she has a diagnosis of type 2 diabetes. So it's quite specific information. At that level 2 data, we've removed the identifiers, so we don't know it's Mrs. Jane Peters and we don't know her actual hard national identifier, but we have retained that important component that there was a diabetes type 2 diagnosis in 2015 on that date. But of course, that is slightly disclosive. If you imagine I replaced the diabetes type 2 diagnosis there with, say, Ebola, and it was a condition, a case in the UK. We had so few cases during the most recent outbreaks of Ebola that you would be able to identify that person just indirectly. And then at level 3 data, we've changed that. We've taken away that idea of the date component and just said this person's had a diagnosis. Of course, that doesn't solve all the problems. It wouldn't solve my Ebola problem, but so you have to still have governance around it, but it does take away, say, that twins problem, or where the event level data, the high dimensional data, is the thing that can be disclosive. So actually using that really powerful data and SNOMED CT recorded data, but then giving the researchers the data quality they need, but reducing all possible disclosure was the technical architecture that we've aimed for. And the really important point from that then is there's no need for any external data extraction. We haven't taken any data sets out of that secure data environment. The huge primary care, as I said, comprehensive data record for, in this case, around 24 million people. We haven't had to move those around. So it's securer, it's easier to do because you're using existing infrastructure, and we've already started to control who can access what data in order to preserve confidentiality. I would say another really important component of this, and a real learning point for all of us involved, has been that the EHR developers and the EHR vendors have worked together very closely to do this, with the authorities as well, so with the NHS in the UK. But I think too often we've been in a situation where people wanting to do analytics and research on high quality healthcare data have kind of not been able to speak to the people who maybe work with that day-to-day basis, and aware of some of the difficulties and challenges of working with that data. Some areas where there may be very good data quality, some where we may be there's less confidence in what data has been recorded to enable us to do things, or that the epidemiologists will have a question that they wonder if there's a way of, for example, identifying a proxy for that in EHR data, but how do they actually speak to the people who may know if that's possible? And for this, I think there's been a really interesting development inside of Ben's team in Oxford University, in that there's a sort of new group of people that we would call developer epidemiologists. So they are developers, genuine software developers. So they speak the language we do here as an EHR vendor in our development team, in terms of us writing code and writing database architecture, etc. We are all speaking the same language, but at the same time, they can talk to the epidemiologists around risk and bias and exposure, and they sort of straddle these two areas. So we've now, via these developer epidemiologists, got this lovely way that the research teams and the development teams can speak together, and we did. The approach has been to do this in a really agile way as quickly as possible. So that means that we've had an open Slack channel the entire time. We've been having 10-minute meetings when we've needed to, rather than scheduling them in for 2 weeks' time when we just didn't have the luxury of months and months to do this. So actually having those small teams working closely together has been very, very powerful. So what data have we ended up with? Well, we now have in this data set, as I said, that full primary care EHR data, which is the real richness, and I would say in terms of size, about 99% of all the data that's held on this database, which we are calling the OpenSAFELY platform. On top of that, we've got emergency care data, we've got intensive care data, national death certificate data, laboratory test results, and most recently some high cost drug data to do some new analyses. There's a mix of terminologies involved here, but the primary care EHR data is all linked to SNOMED CT and to a primary care SNOMED CT data set that's been developed in the UK over the last few years and is now in routine use across all UK primary care. And similarly, components of the emergency care data, the intensive care data set are again SNOMED coded, using the breadth of that terminology enable us to do that. And I think that's been really powerful. What it means is we have the granularity of data that we need to be able to break down the analyses in both demographic and clinical settings, as we'll see, and also to make these kind of analyses reproducible as we go to other UK data sets and expand collaborations internationally with other partners. So the scale of what we're talking about, this is really is a big data set, which has enabled us to do powerful analyses, and it whilst we have all seen the tragic sort of excess deaths that we've had across the world, certainly in the UK, with COVID-19, when you start to drill down into certain categories and you want to know, what's the risk of a 55-year-old Bangladeshi man living in a certain part of the country, actually you're still working with very small numbers, so you do need to have data at this scale to be able to do this analysis. So we have 24 million EHRs in that linked data set that I've just told you the components of. And that spans around 20 billion rows of data, which if we look at the history of that, as I said, we've got this sort of comprehensive longitudinal record in the UK. It gives us about 7 billion patient months of data in total. And when you look across that entire data set, there's 350,000 distinct SNOMED concepts. So then, as I say, the granularity of being able to determine, really specific diagnoses or symptoms, as well as medication data, using the terminology has been a big aspect of how powerful this can be. So what were the key analytic questions we were trying to answer here? And the analytic questions that the governance permissions that came from the top of the NHS and the ethics committees have allowed us to look at collaboratively. Well, to start with, to determine which people are at the highest risk of a poor COVID outcome. So hospital admission, intensive care or death being those primary outcomes. But also we've gone on to look at, can we rapidly assess specific hypotheses around treatment and prevention as they arrive? So some of the drug exposures that have been widely reported in the press, can we try and establish if there is an evidence base for these using that data? Of course, we're very interested in disease modelling and to look at surveillance and disease spread, and that as we're entering a second wave here in the UK, undoubtedly, it's very important that we're able to use that data to be able to look at local spread and local infection rates, and then risk scores of people there, and what local R values are, in order to try and do more accurate disease monitoring and predict for the authorities better. We've all seen, of course, that there's been an impact on all health services by the pandemic, certainly with remote working, with lots of doctors having to self-isolate, and with some delays to certain ongoing procedural care or referrals, for example, for further investigation. So part of the analytic ask here is, can we measure and mitigate any of those indirect health impacts? So what's the impact of people, say, for example, not having retinopathy screening or having slightly delayed cancer referrals, and how can we help to address that? And then finally, to rapidly evaluate the impact of any national interventions, especially on specific patient groups. So in the UK, that's been a big focus on the Black and ethnic minority cohort who are having disproportionately poor outcomes, and anything we can do to understand that better and mitigate against it. So our first output, we believe, is still the largest COVID risk factor study done anywhere in the world. This was on 17 million comprehensive EHRs and was looking at all those risk factors associated with poor outcomes, and in this case, really COVID-19 related death, using that platform. This was published in Nature about 6 weeks ago, and what we tried to do is to explore in a descriptive way all the comprehensive risk factors. So some of those are demographic, so social deprivation scoring, ethnicity, and then age and gender, trying to get a really good handle on that. But lots of them are using that rich SNOMED coded data to try and get a better handle of clinical situations. So what's the impact of being hypertensive, of type 1 diabetes, type 2 diabetes, chronic kidney disease, so a whole range of long-term conditions which there's definitely been associations with and have been reported from the very start of the outbreak that were responsible for people having poor COVID outcomes. Can we really get the evidence-based handle on that? And what we hope is that, of course, this is UK data that's enabled us to do this, and it's an area where we do have that strong data set. And other areas around the world have other fantastic resources to do things, but this EHR data in primary care in the UK is very powerful. But hopefully this is useful, internationally, to help people look at risk factors and to start to think about approaches to mitigating against second waves, etc. It was interesting for us to see how that was picked up by different sources around the world. Of course, lots of the scientific and medical journals were publishing, information about those risk factors, but also, with a situation we're in where so many people are so affected by this, that just more major news outlets, so the New York Times running a story of what those risk factors were and what that meant for people. But also the methodology of doing this was picked up by some people. It's been a very interesting way of doing things. So The Economist, their focus was really on this way of using those medical records inside the environment which they're kept for direct care, without shifting data around is a sort of new way of studying medical records, and is potentially a good legacy here that we'll be able to build on to try and do more analytics like this in the future. And of course, we haven't stopped there. We have 8 or 9 major studies taking place on that platform based on the priority questions that are being asked by the Chief Medical Officer and the Chief Scientific Advisor, amongst other people in the UK, to try and answer some important questions. So 2 of the recent publications are around inhaled corticosteroids. So using that data to say, should people continue to use inhalers if they're using them for COPD and asthma, which is really important for people on the ground who are living with those conditions. And the answer is yes, you absolutely should do that. But establishing the evidence base for that is important. And again, looking at the HIV community and looking at the impact of HIV on poor COVID outcomes to try and get, and then actually taking that forward into more research to try and get more granular detail about what those risk factors actually are. Everything we do is published on the OpenSAFELY.org website, so all of those papers are available, and please encourage people to go on and comment and contribute. All the research protocols we've got are made openly available. We're really trying to make this as open as possible, and we want people to help and to get involved. Along those lines, we really are trying to be very transparent and open with the approach here, and to try and help people to be able to generalize into their own research, but also to understand exactly what it is we've been doing. So all of the analytic code for the project lives on GitHub in an open public repo, so you can go have a look and say, exactly when you say you were running it on 17 million patients, exactly how were you defining that? And you can see some of the code there for any programmers watching. This is it's actually fairly easy to read just in English, but it tells you this is how we've defined our cohorts. This is how we've defined different parts of who's been living with a certain medical condition, so that people can take a look, potentially use that, but also comment back if they want to point out any errors potentially that we may have in that, or any improvements we may like to make. From a data situation, and of real importance to a SNOMED CT audience, not just the analytic code, but the code lists we've also made open in the same GitHub repository. So instead of trying to, I think certainly in previous work I've done, it can be very, very time consuming and difficult to come up with certain code lists when you're trying to describe a certain medical condition. And things like, the hierarchies and the relationships are incredibly powerful to help you do that. But there's always subtleties that you need specific clinical input in order to overcome. And you can find yourself doing that work again and again. So the approach here has been with the SNOMED CT code lists and the drug code lists, which are DO&D coded in the UK, which very closely aligned to SNOMED. We've made those open so people can see them, they can reuse them, they can comment on them. And hopefully we're trying to sort of minimize some of the work that many of us end up redoing again and again. So, finally, so hopefully we've helped to change the way that we may be able to do medical research on this very, very powerful data. Everything that's been done and all that analytic code isn't tied to running on the TPP environment with those records. It's possible to take that analytic structure and move it on top of any database, really. So we've tried to do this thing in as abstract a way as possible, in as general a way as possible, so that we can move around. So, for example, if we wanted to run that risk factor analysis in another country with SNOMED CT coded data sitting in electronic health records, that would be very, very easy to do, and would be very interesting to see how well those results generalize or what local differences there may be. So it's really trying to, as a community, to say, this is the way we should hopefully be trying to do analytics, doing it in the open, trying to be transparent about what's happening, but enabling epidemiologists to come up with the evidence base, which can help ultimately with better policy decisions going forward, both for this pandemic and then hopefully as we emerge from that into some of the other health challenges that we all know we'll face over the next 5-10 years going forward. So hopefully we've made a contribution to that, and I would encourage anybody who's interested in the approach or would like to get involved to get on the OpenSAFELY website, take a look and comment on what we've been doing. So thank you very much. Hopefully that's been some overview of what we've been trying to achieve. Like I say, if you've got any questions, lots of the information is available on the website, but there's some Twitter handles there where you can get hold of us, and hopefully we'll try and answer some of those questions if that's taking place over the next few weeks. But in the meantime, happy to take any questions we've got as soon as possible. So thank you very much.
So I'd like to thank Chris for the presentation, and we're now going to move from the recording to an open live Q&A session. Okay, welcome to this live Q&A session. My name's Ian Green from SNOMED International, and first of all, I'd like to thank Chris for his presentation. We seem to be accumulating a larger number of questions for you, Chris. So we'll try and deal with some of these grouped together. So some technical questions first. Did you use R for the analysis?
I mean, there's been a variety of analyses taking place, and they've used some different statistical packages, to be honest. So some of the analysis, certainly for the risk factors paper I talked about, was using Stata, but the functionality, the support has now been added for both R to be run in there and for Python. So some of the disease dynamic modeling that's going on is running in Python. Some of the ethnicity modeling that's going on is running in R. Yeah, so it's kind of a moving picture as to what analytic tools the epidemiologists want that we can then try and support from a technical end, both at the data lab at Oxford and here at TPP.
So this is a nice broad question, and I'm interested in the answer to this one. How did you go about linking EHR data to the external sources?
Okay, so most of the external sources of data that we used had a single patient identifier, and not much more demographic information actually. So in the UK, we have an NHS number, which is a National Health Service number that everybody is given at birth, and that tracks should track all your contacts with the health service throughout your life, really, from cradle to grave. So the external data sets that we've been linking, for example, let's say the emergency care data set and the hospital data, when people have had those admissions or attendances in hospital, that information's got the NHS number on. So at both ends, both in the primary care data and the hospital data, that NHS number's there. Of course, that is far too identifiable. We can't be sharing that information in the clear. So what happens is we have a pseudonymization process that takes place at every side, and what that means is we have a secret alphanumeric salt that's added to the NHS number, and then we hash that algorithm up using SHA-2 for anybody out there who's into technical encryption. What that does is creates a irreversible one-way hash, so you can't get the NHS number back from that, but when the data sets arrive, if those records link, that's for the same patient. So we have this secure mechanism for linking data across these large data sets.
So was the participation in NIHR approved trials tracked in any way in System 1?
Let me get that. I mean, so you can. I mean, this so far we haven't done any trials work with this. It's been population level analytics without, say, for consented trials. And I think it's Charles who's asked the question. It's certainly possible to do an NIHR trial tracking inside System 1 and across systems actually. And to do that, what we would always recommend to people is to use the codes that are in the SNOMED CT UK extension, that are the NIHR Central Portfolio Management System code. So that means that we can have, I think, about 30 codes across this small domain, which say that a patient's been recruited, screened, followed up for a trial, and the numeric associated with those SNOMED codes is the trial number, so the central trial number that's issued by the NIHR. What that means, of course, is that we've then got a way of identifying the cohort of people who have been recruited to a trial and have not withdrawn from the trial, so that you've got that long EHR analytics data and that follow-up data to do further analyses. So what are the conversations we're having around that at the moment? Well, certainly to see how we can support, for example, COVID vaccination trials. If we can get people who've been part of VAC trials and get that recorded onto their record with that trial number, then we'll have that data in the analytic database, and then, for example, can do a very important sort of post-vaccination surveillance, looking at incidence counts of certain conditions that we may be worried about in that cohort, to try and get very, very quick answers, to a very urgent, pressing question at the moment.
And then looking at the time, we'll have, I'll do all these together. Access the data. So first of all, is the data being made available for other researchers? And how, any thoughts on where the data will be used post-COVID?
Okay, so quickly, the data so far has been, it's an NHS England data asset, so it's owned by NHS England in the UK, and we in industry and with the academic side have been working on behalf of the NHS here. So the priority questions really have been driven by the NHS and by the Chief Medical Officer and the Chief Scientific Advisor here in the UK. What we're very keen to do is to onboard more research teams to do this. Of course, this is very, very sensitive data still. So we've got to be very, very careful about opening up that access. But the model that we've made and developed with the academic teams and the engineers at Oxford means that we do have a secure mechanism to do that, but it has to go through that central OpenSAFELY route. So really a big priority for us now is to onboard more research teams. We have done this so far without any funding because we had to, as I may have mentioned, we had to do it very quickly. As funding streams are coming online and we're able to recruit more developers at the Oxford side, which is sort of the pinch point, we'll be able to get more and more people using this analytics platform to answer more and more questions. So I'd say that's a major focus for us over the next 3 to 4 months. The other question was, remind me.
No, I think you've covered both.
Yeah, okay, yeah. Hopefully that's answered the majority of questions. But if anybody's got any more, please just ping me a question on Twitter, and I'll try and answer them.
I was going to say, please contact Chris with any of the presentations. We're going to have to end it here because we're short on time and overrunning otherwise. But I'd like to thank Chris again. I'd like to thank the audience for your attention, and hope you have a good rest of the expo. Thank you very much. Bye now.
Thanks, everyone.